My name is Jeff Schultz. I've been a paramedic now as of this month for 45 years. I spent 20 years in Flint, Michigan. Got transplanted to Mayo 25 years ago. So I've been there 25 years now. One of my passions is A&P. Most people dislike A&P because in a textbook, it's one chapter and they talk about this, this, and this, and this. Hurry up, get to the good stuff. I want to get through the good stuff. So what I've done is, because the paramedic students are no different, they don't want to hear about A&P, is I've taken A&P and turned it into applied A&P. So basically what it comes down to, and what we're going to talk about today, is why do you need to know A&P? Because the next call you get might make a difference of whether you do something to a patient or not, if you understand the pathophysiology behind the body organs and the systems that are in the body. So this program I've developed gives you the whys, or gives you a medical condition and then tell me why it matters that lungs inflate on deep inspiration and deflate on exhalation. So that's the kind of stuff we're going to talk about. We can talk about it at a very basic level, or we can talk at a very advanced level. That's the nice thing about this program. So this program is similar to the one that Joey's gone to at the clinic, except I don't have cadavers in front of me. So we did a quick, about an hour PowerPoint, and then we headed into the lab for 3 hours, and where we worked on the cadavers and ventilated them, over-ventilated them on purpose, under-ventilated them on purpose, punched the lung tissue and made pulmonary contusions. We did all kinds of things to them because you got to know what's going on. I don't want you to come across something for the first time out on the street corner. If you see it in a lab, you can make all the mistakes you want in a lab, and it doesn't matter. Out there, we don't want mistakes. So interact with me, please. There's a lot of information here, and we're going to talk about a lot of different things that I think are important to what you do. I don't care if you're a first responder, EMT, medic, it doesn't matter. I do this for some of our EMS fellow physicians that drive around in the little, we have doctors that follow us around on ambulance calls in Rochester. They're in a little Suburban, and they'll just come up to a call, hey, do you guys need any help? No, we're good. They'll take off. Or they'll come in and give us a hand. And so, but they go through this same thing with me to kind of understand what we do and how we do it. I don't own stock in back valve mask or PEEP valves or anything else, so I wish I did, but I don't. We're going to talk about A&P of the adult airway. Hopefully when you leave here tonight, you'll have a better understanding of pathophysiology of breathing. Second most popular call in Rochester, respiratory or shortness of breath. First, chest pain. Those are the two #1 calls when you look at the percentages when it comes to ambulance calls for us, like in Rochester. It was no different in Flint. Flint had a lot more trauma than what we get in Rochester, but still medically, chest pain, shortness of breath. We'll talk about handling difficult airways in the field. Then we'll talk about different body systems and their functions. We'll talk about the PEEP valve. We're not talking about the little marshmallow peeps, but we'll talk about what PEEP can do. We'll talk about how do diseases alter tissue and organs. Let me show you an example. So I have the ability to remove body organs, put them in a 3D printer, and then have them 3D print the actual color, texture, and everything. And then I'm allowed to bring these into the classroom. So here, I'll pass this around. This is a sliver of a normal liver. This is a sliver of a liver that's had too much alcohol. You can tell by the shapes, these are from the same area, that this is healthy and that's not healthy. So we'll talk about, different diseases that make this happen and why people turn jaundice. I mean, look at this. You can almost see some of the yellow in it already. There's some green. That's nice red and dark brown. We'll talk about that. We'll talk about heart anatomy and pathophys and then coronary blood perfusion. All right. The biggest question I get is why EMS students say to me, why do I really know? I know where the lungs are. I know where the heart is. I know where the liver is. That's good enough. I say no. I say no. How would you like a brain surgeon? You got two of them. One knows anatomy really well. The other one said, I know where the brain is. And you have to have an operation. Which surgeon would you want? That's what I'm talking about. And people want that EMT that knows more, to understand body systems. So we have to start understanding disease processes. Chemically, no. But the general overview of the difference between COPD and CHF, for instance. They both cause shortness of breath, but they're completely different in the mechanism that's causing shortness of breath, which means you treat them differently. I know some ambulance services that every time they have a patient that's short of breath, they give albuterol. Every time. That's incorrect. Albuterol only works in the alveoli and the terminal bronchioles. If you've got shortness of breath because your airway is swelling, albuterol does absolutely nothing except make you feel better because you're giving the patient something. That's incorrect. So this is why I developed or helped put this together, to give people a better understanding of where does that albuterol go and why does it work. And I'll show you some examples, some tissue examples of alveoli that got albuterol versus alveoli that didn't. And we'll get into that a little bit more. Homeostasis. Now, people that have been in science class in school or taken biology or whatever, they really dislike homeostasis. It's like, God, I hate that word. And I understand that. Your body needs to be in an equilibrium, and most of the time you get paged out to go see a patient, trauma or medical, their body's not in an equilibrium. Otherwise, they wouldn't be calling you. They wouldn't be calling you. So this homeostasis regulates everything like a thermostat in your home, so you can digest food, so you can get rid of food, so you can breathe correctly, so your heart beats correct. It's all one big happy family. That's what homeostasis is. And all it takes is one thing to mess up the whole system. The whole system. Us sitting here right now, your body is using a lot of different organs to maintain your homeostasis just sitting here, and you don't even realize it. Thank God we don't have to monitor that, because we'd be pushing buttons on our body all the time. Oh, I need a little bit more base. Oh, I need a little bit more acid. Oh, I need a little bit more O2. I need less O2. It's just constantly done all the time. And it's really remarkable when you dig into this. I'm not going to go dorky on you tonight, because most people don't really like to get into this. I do. When I go home tonight, I'm reading a chapter on homeostasis in COPD patients right now. And you talk about messed up. That whole COPD is all messed up. They don't have a normal homeostasis. I bring my work home with me every single day. I have a very tolerant wife, because most people would not tolerate that. I bring it home every day, 7 days a week. EMS, emergency medicine, constantly. All right, so we're going to watch this video, and then we're going to talk about this condition here that exists. going on with this guy? You don't know anything about him. It's a guy. Flail chest. When you see this area, when he takes an inhale, his chest sucks in there. When he exhales, it bulges out. The opposite of what it should do. Let's keep watching a little bit more of this. Watch his abdomen. It's going the opposite direction. It's back and forth. Once you see this in the field, you can't miss this. If you never took the guy's shirt off, could you miss it? Yep, real easy. Trauma naked. And we don't like to talk about that stuff, but hey, it's true. You don't strip somebody down, you don't see that, that's life-threatening right there. He'll code on you very quickly. What's the treatment for a flailed chest? It's changed over the years. You can be wrong in here all you want. It's okay. Maybe you don't know. Yeah, what's the treatment for flailed chest?
We can splint it.
I kind of like that. You're headed down the right direction. Some of us, the older people, we'll keep ages to ourselves, remember they used to have to put a sandbag on it. We carried sandbags in the ambulance.
Still do.
Okay, don't do that. That's like 1970 stuff. And then we would splint it with a bulky dressing. That's gone. Now we splint it internally with bag valve mask. We bag valve mask this patient. Even though he's breathing, we still bag valve mask him because the pressure will open up the alveoli, because the area that's flailed, the alveoli that are underneath it aren't open. There's no continuity to the chest. So that area is useless. And I bet you half of his left lung is useless. So his pulse oximetry is in the poo-poo. The only way to get that up and get those alveoli back open is positive pressure ventilation to splint that area from the inside out. That's what we're doing. So that's the new treatment for flailed chest.
What actually caused that?
There's a lot of things that can cause this. I've seen steering wheels cause it. The steering wheel hits and then it fractures that flailed segment. It's 3 or more ribs broken in 2 or more places. That's the definition from the textbook. And that's usually, and it can be bigger than that too. I've seen a whole side. I had a gentleman driving a boat on Lake Huron when I was working in Port Huron, and he run into a cement embankment out in Lake Huron, was trapped in the boat, and the steering wheel collapsed the whole left side of his right side of his chest. And you could, when he was trying to breathe, you could see the whole right going in the opposite direction of what it should have been. So I got in the boat with the fire department. We had to go out and extricate him in 30 feet of water because the boat was wedged into this cement thing that came out like a wing dam, but it was above the water out in Lake Huron. So there's a lot of that kind of stuff in the Great Lakes. So, and his whole chest here was just, he probably broke this, probably all of these right here and over here too. Because the chest cavity, if you think about the chest cavity, it's a circle. And when you break a circle, rarely does it just break on one point. It usually breaks on a second time directly across from it. So there's usually 2 breaks in a circle because of the pressure. That's why the pelvis rarely breaks in one area. It's a circle. If you can envision the circle, usually I have 2 breaks in it if you have a pelvic injury. So I brought this up because a lot of people haven't seen a flailed chest before. They talk about it, but that literally, now you're like, well, they had an oxygen mask on that guy, Jeff. Why aren't they bag valving him? He's in the ER. They're probably getting ready to intubate him and pre-oxygenating somebody so his oxygen saturations don't fall when they get ready to intubate him. So we'll take a look at it one more time. He does have a chest tube in, so the left lung, I was mistaken, I called it the right lung. Left lung is collapsed. That's why the chest tube is in there. to suck out the air, so when he does breathe, the lung reinflates as best as it can. But in this case, it's not going to be because of the flail segment. So what's the importance of A and P to this? The lung is covered by two different membranes, the visceral pleura and the parietal pleura. And what's happened is when that lung collapsed, those pleura separated and air gets trapped in there, and you end up getting a pneumothorax from that too, but that chest tube is helping get that air out. So if you understand that, you understand, okay, we need a paramedic unit, we need a helicopter or whatever, we got to get a chest tube in him, we got to get his needle in his chest to get that excess of air out, and then we're going to sedate him, paralyze him, and then we're going to ventilate him so we can keep those lung tissues open so you can get the oxygen in and get the carbon dioxide out so he remains in homeostasis. Now that's a long, it sounds like a church sermon, what I just said. But that's the why of why you do those things in the field. Because he wouldn't make it from here to St. Mary's, he'd code. Can you imagine if he codes and you got to do CPR? What do you think happens to all those broken ribs in there when you're on your first compression? You're going to slice and dice the lung tissue all up, and now you got a mess. So what happens in CPR, and I see this in some of the cadavers, is where the ribs join the sternum is they call it the costal joint. Those, because there's cartilage in between them, when you're doing compressions, they'll break right here usually. I have seen a couple break here, but not usually. It's usually right along the sternal border if that happens. We try not to, but I call it collateral damage. If you're doing good, I've heard people say, do CPR till you hear the ribs crack. No, don't do that. Do it 2 inches like you're supposed to. And if the ribs do crack, okay. And if they don't, okay. I can tell you this, Dr. White and a couple of other researchers at Mayo looked at patients that had their ribs broke during CPR that survived, and patients that didn't have their ribs broke. The ones that had their ribs broke had a 2-week longer stay in the hospital, which costs the family more money. Now, if they break accidentally, that's okay, but I've seen people, I'm going to keep pushing until I hear ribs snap. No. You guys have a Lucas device, don't you? Or a life belt or whatever? I haven't seen too many rib fractures with that, I'll be honest with you. Normally, if you're doing compressions, you'll only get single breaks. I've never seen a break where it's broke here and here. Let's take a look at this one. Look at this flail segment. And this is from a boating accident. So when he takes when he inhales, that segment goes in. Watch it again. This guy's on a boat. He's in trouble. He's still conscious. They have him on his left side because air rises. So you might have to transport somebody on their left side. Like if that's a big flailed segment. That's more than 3 ribs broken. I can guarantee you that. So, you know, the old days, everybody gets a C-collar and everybody gets a backboard. That's kind of going away. I haven't used a backboard in over 12 years. Don't use them. Don't need to. Studies show that these people that have spinal injuries, we actually make them worse when we put them on a backboard and drive from Rushford all the way to St. Mary's. So now what we're doing is we're just C-collaring and putting them in position of comfort on the cot and making sure they're not moving excessively. That's all we do. So we got rid of our back. Well, we didn't get rid of them. The state says you got to have them, but nobody ever opens up the compartment. I've used a backboard to quickly move somebody, like an injured athlete, a scoop stretcher, or a backboard to get them off the field. But other than that, so okay. So paradoxical movement, that's what that opposite movement is, occurs mainly because of two factors. You have no continuity in the chest, and the negative interpleural pressure is acting on the detached segment. So it's separated from the rest of the chest. So like this area right here, if it was broke here and here, here and here, here and here, that segment's separate from the rest of the chest. It's very interesting. I love this stuff. And that's what this is showing. That's the fractured segment right here. That's expiration. And it goes out. Inspiration, it gets sucked in. It's a negative pressure, negative of what it should be. Anybody ever go to school where they had that glass bell? And inside the bell, there were two balloons on a Y thing. And on the bottom of the bell, there was a latex membrane. And they would pull it down. And all of a sudden, these balloons would inflate. And you're like, how does that happen? Well, you create negative pressure inside the bell. And air will move from positive to negative and fill up the balloons. That's us. But when this happens, it messes that up. So you got to understand the territory that you're working in, because you can go from delivering a baby one moment to doing a STEMI or a cardiac arrest the next moment to doing a femur fracture an hour later. That's EMS. That's the way it is. I can't control what calls I go on. I wish I could, but I can't. We're expected to know, not physician A&P, but we're expected to know a little bit of what's going on, especially paramedics, because we carry 62 different medications that affect many body systems. You give the wrong medication to the wrong disease and you're in trouble. So remember that the anatomy for the respiratory system begins right here and then goes all the way down. So I have a question for you. It's kind of a trick question. Is the respiratory system from here all the way to the base of the lungs an open or a closed system? Let's think about it for a minute. Is it open or is it closed? Both. I like it. Both isn't that far off. So I think it's open, and here's why. The oxygen has to cross a membrane to get into your bloodstream, right? So is it true, if your respiratory system was closed, oxygen would never go to your bloodstream. You would suffocate. And then your carbon dioxide needs to cross out of your bloodstream and into your lungs so you can get rid of it. So technically, it's an open system, but when somebody said both, there's a one-cell membrane that separates the alveoli from a blood vessel. One cell, that's it. Imagine somebody's lungs and the alveoli filling up with fluid. How easy would the oxygen go across? It'd be tougher than tough. Pulmonary edema, CHF, is an example of that. Don't forget, if you don't get rid of carbon dioxide, you will die. If I took a tank of carbon dioxide and gave this gentleman a mask, and I hooked it up to the tank of carbon dioxide and it turned it to 15 liters, probably in 10 minutes, he would be dead. Because I'm pumping him full of carbon dioxide. Well, you make your own carbon dioxide. If you don't get rid of it, it accumulates in your body, turns your body into acid, basically, and your organs can't work and you die. That's the reality of it. And I think people forget about this. I got good chest rise. Okay, but are you getting the carbon dioxide out? That's the other danger person here, the asthma patient. They can get air in. You've seen their chest. You can hear them wheezing. They can get air in, but they can't get it out. And that's dangerous. That will kill them. All right. This is literally a embalmed head that we were able to split down the center on a bandsaw. Yep, literally a bandsaw. I have one up in Stabile, it's big. So I cut the head in half so you can see the airway stuff here is what I'm interested in. In fact, the brain's removed, it's not even there. So look at all of this stuff that can go wrong. Facial trauma. Has anybody heard of Lefort fractures? Lefort fractures were not invented, but found out in the medieval times. There was a doctor, Lefort, that lived in a medieval castle. When they beheaded people, for whatever reason, he would collect their heads and put them in a bucket, go to the top of the castle, take their heads, and drop them onto the rocks below. Then he would go get the heads and take the skin off of them and see the fractures that were in the face. And he found out that there's 3 styles of fractures, Lefort 1, Lefort 2, Lefort 3. And they all affect the airway because you can't hold your face up off your airway. And that is stuck until this day. They still teach Lefort fractures and what to do for them in the field. Hopefully you never see one, but I've seen some where the person's ate the windshield. When we get there and this part of the maxilla is actually sitting lower than the mandible. And they're trying to talk and it's moving, but we got an airway problem. You don't have to memorize all. This is a nasal cavity right here to me. That's what I need to know. Your nasopharyngeal airways, they go up, in, and sit right here. When we were in the lab, I actually showed, I have a video scope, I can go down, you can see the tip of your nasopharyngeal airway in the back of the throat. Most people don't realize that, but it sits right there. That's why there's such a good airway. I like them better than I do oral airways, nasopharyngeal airways. So this gets a little bit more detailed. This was a specimen that had liquid latex pumped into the blood vessels in the face and airway. So we drained the blood and we pumped liquid latex in. So the red are arteries and the blue are the veins. Just look at how many blood, and this doesn't really show them all, but there's your uvula. Everybody got one of those. You can see it in the back of the throat. Well, that's a side section of it right there. So if you were looking down here, you'd see that hanging in the back of the throat. Here's your nasopharynx, where your nasal airway goes, and there's your oropharynx. When you put your oral airway in, it holds the tongue up off the back of the throat. That's what an oral airway does. And we practice on Fred the Head. Everybody's got Fred the Head. Was it different when you put them in a cadaver? 100% different. Fred the Head, you can stand back here and do a hook shot, and the airway will just fall into his mouth, and you're like, I did it. It's a lot harder on a real person. This is one of my most favorite slides. This is that same patient, but we're looking at the patient from the back side to the front side. So I shaved off his neck, and this is his epiglottis right there. So when you swallow, it would fold over the trachea, and your food would go down the esophagus. And you're like, okay, well, so what, Jeff? Who cares? I care because look at the carotid artery and how close it is to the airway. External jugular vein is right there. Well, big vein, everybody, you can see them if you lay somebody down and turn their head. And look at all the other blood vessels in there. And you wonder why during an anaphylactic reaction or a trauma event, why that airway swells up so quick? That's why. That's why. That's why it's important to get your EpiPen on board ASAP. We used to kind of wait on that stuff. Now, if you have an allergic reaction and I see at least 2 signs and symptoms of an allergic reaction, I don't care what they are, they're getting an EpiPen immediately. Because I don't want to deal with a swollen airway. I had a lady who was on a snowmobile who took a barbed wire across her throat. She was 28 years old, lying in the snow when we get there, she's bubbling. We're suctioning, I'm getting ready to intubate her, and I look, and I can see down the trachea. I lifted up the epiglottis, and there's just blood pouring out of here. Still suctioning. All I seen was air bubbles. Couldn't see the vocal cords, and I'm like, I think that's the trachea. So I took the tube, and I put the tube in there, and as I pushed the tube through, I could feel it catching on something, and I'm like, what's it catching on? Well, I'll show you in just a bit what it was catching on. So I divided the lower airway into 2 regions here. Anything below the vocal cords or the larynx, anything below is the lower airway. The upper airway is anything above your larynx. Literally, that's the truth. And then I took this lower airway, so the conduction region brings air into your lungs, and where does it exchange? Terminal bronchioles and the alveoli. So I just divided the lower airway into 2 sections. Your albuterol works here. It does not work here. Here's a trachea that I removed. This is the stomach. So they're upside down kind of. But this is the epiglottis, and that would fold over your trachea. Look where your esophagus is. It's the dark part here. How easy is it to choke? Go out and have a few drinks, can't swallow right, chew your steak, didn't chew it good enough, try to swallow, because alcohol decreases your swallowing reflex, and that steak gets caught right in there, and you choke. This is that same airway, but now we're looking at it from the front. These are tracheal rings, and that's what that tube was getting caught on. She fractured 3 of her tracheal rings, and when I tried to push, the tracheal rings were pushed into the trachea, and it was catching on them because they're made out of cartilage, and you can fracture them very easily. They're just like a bone, except it's cartilage, and like I said, you can fracture them very easily. If you notice, they're horseshoe shaped. There's your esophagus, and there's no cartilage back here. The backside of your trachea is soft and pliable. Why? There's actually a reason why. Can you imagine chewing a nice piece of summer sausage and you swallow it? If you had tracheal rings all the way around your trachea, as the food would come down your esophagus, it would go click, 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 click on every single ring. Because these stay married until you get down to the abdomen, and then the esophagus goes through the diaphragm and into your stomach. And of course, your trachea ends at the lungs. So there's a thing in A&P they call form to function. It's formed this way to function correctly. So your trachea they're only horseshoe-shaped rings. There's nothing on the backside other than skin. When we used to do the burp maneuver, you would push on it 5 to 8 pounds of pressure. It was supposed to pinch the esophagus off so air wouldn't go down in there. Now they got rid of that. We don't do that anymore. The burp maneuver, back, up, right, and 5 to 8 pounds of pressure. So we used to do that when we bag valve somebody. They wanted you to push on the trachea to pinch off the esophagus, which lies right behind it. And it doesn't work. So this is a microscope view of a hyaline tracheal ring. So this is the cartilage right here, and it looks like bone, but it can break. I break them in the cadaver lab on purpose to show people how easy it is to break. Here's that visceral pleura and parietal pleura I was talking about. Parietal pleura lines the inside of the chest cavity. The visceral pleura lines the lungs. And you're like, well, I don't care about that. Who smokes ribs here? I do. I got a big Rectex smoker at home. I got ribs going all the time. But before you smoke ribs, what do they tell you to do?
Take the fence off.
Yeah, you got to take the parietal pleura off the inside of the rib cage and peel it off. It doesn't taste good. It's not good for the ribs. And you're like, well, I don't really care about this stuff, Jeff. Well, what happens when you get air between the lung and the chest, the inside of the chest wall?
Friction rip.
Air presses down on the lung.
Yeah, you get a pneumothorax or a tension pneumothorax, and your patient can't breathe. So, let's look at this patient. This patient is standing here in front of you like this. Left side is this side, right side is this side. To spare you the long story, this is an x-ray from me in 1986. I was involved in an ambulance car accident in the city of Flint. I was seat belted in, I was the passenger, my partner was driving. We were responding to a car accident, and there were cars lined up on Miller Road in Flint for miles. And we were trying to get around them. Well, some car decided they weren't going to wait, so they did a U-turn in front of our ambulance, and we broadsided them. The next day, I got up and, geez, I'm sore. I don't feel good. I'm coughing. I'm going to work. Put my uniform on, went back into work, started running calls again. Halfway through my shift, I just told my partner, I said, go up to Flint Osteopathic Hospital and have Dr. Jewell write me a script for Zithromax, because Zithromax fixes everything. Z-Paks fix everything. I said, I think I got pneumonia. That's what I thought I had. I don't know why. So I got up there, and Dr. Jewell listened to my lungs. He's like, I'll give you a Z-Pak, but run down to the x-ray department and get an x-ray. You didn't have to go through all the rigmarole. They took care of their paramedics over there. So I walked down to x-ray, and Dr. Jewell wants me to have a chest x-ray. The chest x-ray, they put it in the envelope. They gave it to me. I walked it back to the ER and said, here you go, doctor. And he puts it up, and this is what I've got. This is my entire right lung. You can see all the nice kind of opaque, kind of misty type. That's lung tissue. That's all normal. Here is my lung now, my left lung. It's all collapsed, and that's why it's darker. This black, free air pushing on my lung. A tension pneumothorax. I didn't have subcutaneous emphysema. I wasn't short of breath. My pulse oximetry was 96. I didn't have any of the book stuff. Patients don't read the book. I didn't have nothing like that. So I end up, he looks at it and goes, yeah, take your uniform off. You're going to be here for a while. And I'm like, well, why? He says, cuz. This is why. They put a chest tube in me. Fifth intercostal space, mid-axillary line. You still got the scar. It's pretty big. So they suck out the air that's in there. So when I breathe, my lung starts to reinflate on its own. So they created a negative pressure in here, and I breathed in positive pressure, and that it's like a balloon. It inflated. 2 days with a chest tube, pull the chest tube out, sew your hole shut, x-ray again the next day, went home. Couldn't work for 90 days. That sucked. This was the second year of my paramedic program in Lansing, East Lansing actually. My instructor drove all my homework over to me from East Lansing to the town I lived in. Gave it all to me. She says, you're going to do a presentation on tension pneumothorax when you come back, and all your homework's going to be completed. So I did everything from home for about 3 months. And I did fine. No issues. So remember, if we back up here, This is the parietal pleura. This is the visceral pleura that's on the lung. And air got between them. That's not good. Normally, both of those membranes, when you take a deep breath, they just rub against each other. And when you get pleurisy, you get a rub where those dry out. That's painful. So let's see what happens with a patient in the field that needs to get the air out immediately and the paramedics show up. I have many friends across the world. That's how I got this video. I did not put the music to it. They did this, so. So here goes a needle, a 14 gauge needle in the chest cavity. Parietal pleura is here. Visceral pleura is literally on the lung tissue. The air is rushing out. It's moving out. And the patient's breathing. Look what happens. What happens to that lung tissue? It reinflates immediately. Immediately. So his pulse oximetry is coming up with every breath. And it doesn't matter if it hits the catheter. He's going to get a chest tube anyways. It's one of the best videos ever. Just how fast does a needle decompression work? It works that fast. This is live. And the patient's breathing on their own. So he's not being ventilated. That's how fast it works. So when you see those medics putting those needles in, they're doing it because we've got to get those lungs reinflated or get the blood. Sometimes there's blood in there. Got to get the blood out. Otherwise they don't inflate. I already talked about this. O2's got to get in. CO2's got to get out. 1 cell thick. That's all it is. Between the alveoli and a blood vessel. 1 cell thick. And here is real alveoli. They don't look like grapes. In the textbook, they show you this little grape thing, and you're like, oh, nope. These are alveoli. Look, this is an alveoli. This great big long thing right here, that's an alveoli. Why aren't they perfectly in circle? More surface area. If they're jagged, they get more surface area and you can exchange oxygen better and you can exchange carbon dioxide better. That's why they're oblong and they're weird looking. But you can see, I mean, this one's kind of in a circle as we go in further. But this is under a micron microscope at 400 times. So when you give albuterol, it's got to get all the way to this membrane. It's got to get all the way down there. And there's little tiny receptors in there. You can't see them, but they're there. And when the albuterol hits the receptor, poof, it tells the alveoli to get big. And if we get big, the wheezing goes away and you get better gas exchange. That's why I show this. This is normal lung tissue right here. It's normal. There's no disease in this lung tissue at all. So the blood vessels are in between the membrane. That's an alveoli right there. It's really weird shaped. Kind of looks like Texas. These 3 things are important to you because you can control them in the field. You ever seen anybody ventilate too fast? I have. Don't do that. I want you to take a deep breath on your next cardiac arrest, and I want you to think, I want to have fun. You can have fun at cardiac arrest. As a matter of fact, you can pass this around. It's a pin that I had made. And I had it made because I taught a class that was called this. Codes are fun. Now the reason I taught that class is because I seen an ortho surgeon for my shoulder. I goaltend in hockey at least 2 to 3 days a week My shoulder dislocated, so I ended up having surgery on it. This surgeon was so excited about working on my shoulder that I was blown away. I'm like, geez, you want to cut me open and work on my shoulder? Guess what? He's the top-notch shoulder surgeon in the world today. Because he likes what he does. And people that like what they do tend to do a very good job at it. Not always, but tend to. So I tell people, relax at the code and enjoy yourself and ventilate one breath every 5 to 6 seconds. Not one breath every 2. Hurry up, get in here. I'm not going to hurry. I want to have fun. If I hurry, my fun gets done. Do you want the roller coaster ride to end when you're a kid? Well, no, you want to keep going. So my point with that is, kind of hypothetically, is we need to calm down. We need to control the rate we're ventilating at. And we need to control the volume. You don't have to give the whole bag valve mask. We used a pediatric BVM on a 220-pound adult. And I had the chest plate removed so you could see the lungs. And the lungs were fully inflated with a pediatric bag valve mask. And nothing was going in the stomach, because that's a problem in the field. What goes in the stomach comes out of the stomach, and it's not favorable usually. So we need to control the volume, the rate, and then the last thing is make sure your O2 tank isn't dry. That's happened. That's happened to me, I'll be honest with you, where I've had the tank at 15 liters because I'm ventilating. I look over and it's empty. So make sure that the amount of oxygen you're giving is right, the volume's right, and the rate is right. That's something that all of you can do on every call where you're ventilating somebody. We'll talk about resistance and compliance in a little bit when I show you some diseased lung tissue. Carbon dioxide's blue, is going out, and the oxygen red is coming in. And this is the blood vessel right here, and that's the alveoli. Everybody agree that kind of looks normal? So tell me what's going on in this next picture. What is that? Take a guess. An embolism. It's a blood clot in the blood vessel blocking the gas exchange. So 50% of the exchange in this picture is gone. So it's a pulmonary embolus. It's a blood clot, is all it is. Do you know who is really vulnerable for that according to the textbooks? And I'm going to stereotype here really bad because the textbooks, I didn't make this up. Women, overweight, high blood pressure, smoking, birth control. 5 things. So those are some of the questions I ask if I get a female and they're, I don't care what age they are. I'll ask them those, do you smoke? Do you take birth control? And I go through the list because I can start to narrow down, why are you short of breath? Do you have any respiratory problems? Nope. That's what the textbook says. Can guys get them? Absolutely, but women are more prone to them. What's wrong with this one? What happened to the alveoli? It collapsed. That's what they're trying to show here. No gas exchange. Collapsed lung. That's exactly what that picture is. Yep. All right, this is the cool stuff. Good lung tissue, bad lung tissue. There's a reason I have this. Patient didn't make it. That's pneumonia. That's pneumonia. This A is pus and infection. And all of this is. And you can see how the alveoli are supposed to be. So you're giving a neb. And you're rightfully to do so, because where is this infection located? In the lower airway. The neb is going to bronchodilate a little bit. But what does this patient really need? Something that we can't provide in the field. Antibiotics. We have to get rid of that infection in order to open up the alveoli again. But they might be wheezing, so you give them a neb treatment. That's acceptable. It's not, I mean, that's okay. Let's take a look at this next one. Here's the good lung. Ooh. Let's all go outside and vape, because after a while, what happens is all that smoke goes in and dries up the alveoli and makes all the blood vessels shrink down to nothing, so you can't get gas exchange at all. You can't, no matter what we do in the field. So remember that next COPD patient you run on. Think in your head, that's what his or her lungs look like. And I have opened up people in the cadaver lab, and I looked and it's like, whoa. You can see they have the barrel chest. Before I do anything, I stand back and look at them. And I'll say to myself, because I don't get any history on the patients that I work on, I'll say, that person's a smoker. And sure enough, you take off the chest plate, you see the lungs, black. They got black spots just all over them. And you're like, oof. You know, I can pretty much figure out why this patient expired. I leave this in here because for the National Registry exam or the EMR exam even, they still say mouth to mask is the best technique to ventilate somebody. The textbooks still say that. Yuck. I have not done mouth to mask in, I don't know, 30 years. Why do you think they still say this is the number one way? Tidal volume. All of you in here have a tidal volume of somewhere between 400 and 800 mLs of air that you can put into your lungs. So if I was doing mouth to mask on him, it would be really hard for me to overventilate him, which is a problem if we overventilate. Anybody in here, it would be hard to overventilate any of you in here if I had to do mouth to mask. Probably the biggest one we use is the second best, which is two-person bag valve mask, because we have enough people on scene where I work at that we can do that. So that might not be the case here, depending on who's available for a call. So a lot of times we end up doing this, and that is the worst method for ventilating somebody, believe it or not. This right here, and I'm hoping you don't have one, is the demand valve, where you push the button. And as long as you push the button, the air shoots in. Tell you a horror story about those devices. Back in the early 80s, a lot of rescue squads had them. I went on an 8-year-old boy who fell into a pool, and a state trooper in Michigan dove in and got him. He had been in the pool for a while. And a volunteer fire department got on scene and pulled out the demand valve and started ventilating this kid. Well, what they didn't know is they didn't release the button. So he filled up with air until his lungs burst. And then the air started to leak out underneath his skin. When I got there in the ambulance and I looked, he looked like he was 16 years old. He was 8. It filled him up like a balloon. And I looked at it and I'm like, are you kidding me? What are you doing? I got upset. Normally I don't. I got really upset. The kid died. He probably would have died anyways, because he'd been in the pool for like an hour under the water before the call came in as a missing child. And so all the police department was looking for the kid in the neighborhood. And a state trooper happened to look over a fence. The kid pushed the gate open and he was in the pool. So these went away. Can they be used correctly? By all means, but we've just kind of gotten rid of them. I have a couple at the college that I'll take up to the cadaver lab and purposely hold the button to blow out the lungs to show people what they do. But no more on the ambulances. We got rid of them. Here's some lungs that got removed a few weeks ago that I took pictures of. See that nice shiny surface? That's the visceral pleura. Nice and shiny. It's a little tiny thin membrane. So the right lung got 3 lobes on the right lung and only 2 here. Why? What's right here? The heart. Yeah, exactly. So we've got to make sure we don't injure patients, and if you ventilate too forcefully, you're going to injure them. You'll pop the lungs. That's not good. On anybody. How about somebody with COPD? If you're ventilating too forcefully, that lung tissue is already diseased and damaged. You can pop the lung really easy. Then you have a pneumothorax. So you rupture the alveolar walls, and that's what I was just talking about. You can get air in the mediastinum, which is the area like in here. You can get a pneumothorax out here, and you can get a gas embolism. I've never seen that, but I suppose you could. But I have seen these two. There's normal inflated lung tissue right here. You'll never see this in the field, ever. I hope not, at least. But so these are the bronchi. This is the terminal bronchiole. These are the respiratory bronchi, and now our alveoli are all down in here. This is a great picture. This came from. I was doing some work at the pathology department, and they were doing an autopsy, and they pulled this out, and Dr. Aubrey was able to. It was just a perfect picture, and it couldn't. She's the one that labeled it for me and everything. And this really sends a message home. This is very, very delicate tissue. I wish I could have brought a lung in tonight, because when you poke it, it's like the Stay Puft Marshmallow Man, but it's pink, and it's delicate. You can actually pinch it, and you can feel snap, pop, because all these little alveoli are popping when you pinch it. That's how delicate it is. So you get somebody that slams into another car and their chest hits the steering wheel. Don't forget, these lungs still move inside your chest. So what I'll do is I'll take I usually take some device up in the lab, and I'll bam, 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 I'll hit the tissue. So I create a bruise on it, and then we ventilate it, and you can see it's all messed up. It's all messed up. Don't forget, all the little blood vessels in here, they break open too and leak blood. So there's normal ventilation. Look at that, that's overventilation of alveoli. You're the first group that I've showed these 2 slides to, by the way. I've never used them before. I didn't have them when you came through. I had just gotten these. This was an EMS crew that will remain nameless. This isn't why the patient died, by the way, but it was a perfect example of overinflated lung tissue. It's just way too much. This was an actual asthma patient. Look how swollen some of these walls are, and the air was trapped in there. Couldn't get out. Here's an embalmed cadaver that we use, and I like to show this. So there's the right lung, there's the left lung. The heart sits right here, and then the diaphragm sits kind of dome-shaped right there. And it's not that thick. I had some people in the anatomy lab last week that said, "Oh, show me the diaphragm." So I grabbed a pair of tweezers and I just pulled up on it a little bit. There it is. Oh, all the pictures in the book show. No, it's not that thick. And then what happens is from the brainstem, and you can't see it, well, might be right here. This little thing right here goes down. That's the phrenic nerve. The phrenic nerve runs up into your brainstem, and that's what controls your diaphragm. So if you're shot in the chest and the 9mm bullet goes through and severs that nerve, you're not breathing. And you're like, how can one gunshot? Well, if it severs that nerve, that's what runs your diaphragm, you're not breathing. So it puts it into perspective that one bullet, a 22, I don't care what it is, can do that kind of damage. Yep, that nerve right there is the phrenic nerve. And that, like I said, it goes down and attaches into your diaphragm and makes your diaphragm go up and down. I was able to be trained on this in about literally 15 minutes. I was in the cadaver lab and we were putting them in cadavers just to test it when we initially went to their backup airway for us. But I'm like, wow, that was easy compared to the King, compared to the combi tube and all those other things they put out over the years. Nothing to inflate. You look for chest rise and boom, you're good to go. And so I'm very impressed with this airway. And normally I usually find something wrong with one of them. I haven't really found anything wrong with this. So this is a great video, by the way. I don't know what he's saying, doesn't matter. You can still see he's kind of breathing a little. He's checking for no gag reflex. Look at this. Whoop, right on down. Boom. Feel that little, did you see that little click there? We'll look at it again. Now he's ventilating. That little decrease of resistance means it's seated over the trachea. That's what you want to feel. That's when you put that in. And you're going to be okay. And you can see what they're showing here is the ventilations. Here, the inspiratory, expiratory percentages of O2. Of course, inspiratory, you're going to have more. Expiratory, you have less. This is 95. We don't look at expiratory in the field. We just look at pulse oximetry. And anesthesia, they look at both. So he's using a anesthesia bag back on the machine to ventilate him. That's why you don't see the bag valve mask. He's using an anesthesia bag. Okay, let's watch that again, just to the point of where you see him put it in. So they're pre-oxygenating him is what they're doing. Actually, they put him to sleep with the gases. And the reason I like to show this is maybe you've never seen one put in. It's possible. Pushes the tongue out of the way. That's all he's doing. So it can go in easier. I carry tongue blades with me. Now watch when he gets to a certain point, you'll see it give, boom. That's it. That's all you need. Don't keep shoving it. Stop there and ventilate. You're done. Up in the cadaver lab, I will purposely push them too far, and I will not push them far enough and make people kind of, oh, let's troubleshoot this. You do this in the field. That's why I wish I could do it here. It'd be fun. Okay. But I at least wanted to show that. Let's talk about intubation quick, because every paramedic's good at intubation. At least that's what they'll tell you. This is a 4-year-old in for an elective surgery. So they're going to intubate him. And they've got a laryngoscope in. They pick up the epiglottis. And that is the vocal cords. That's it. There's no neon sign down there that says put the tube here. It looks just like that. The esophagus is sitting down here. These little cartilages right here is what I look for in kids, because I know those are called arytenoids or posterior cartilages, and I know directly above it, you can start to see it. That's where the vocal cords are. So I don't even look for vocal cords. I just look for those cartilages, and I know if I put the tube right above it, I'm in the trachea every single time. This is a different kid. I think this is a 6-year-old. That's it. That's all the room you have to put an ET tube in. There's no vomit here. There's no blood here. There's nothing here. This is in an OR where the kid hasn't eaten for probably 12 hours. That doesn't apply to us. We pick up the local drunk at the bar that fell off the bar stool, hit his head, and he's throwing up nachos and beer. That's an unpleasant situation. This is an adult here. It's very dark down there. So that's the tracheal opening there, that dark area there, because it sits below the trachea. Remember, they're lying on their back. That's the esophagus. So there's a lot going on in an airway like this when that medic goes to intubate. Gotta know the territory. You have to. This applies to you. Paramedic intubates and they say, here, bag the patient. You're like, okay. Have you been taught to ventilate a patient with an ET tube in place? It's a little different. But I had an EMT once, my fault here. We were coming out of the ambulance and I had intubated the guy and I had handed it to the EMT. It was a firefighter in Rochester. And they're pulling the cot fast because you got to hurry. They're pulling the cot fast. And the EMT's trying to keep up. And the cot went out and the tube slipped a little bit and she just pushed it back down in and kept ventilating. It actually came out of the trachea and went into the esophagus. And we get into the ER and Dr. Russey's listening and going, this tube isn't in the lungs, it's in the stomach. And I'm like, no way. Well, that ended up happening. She came to me, she said, I think the tube moved on the way in. Of course, what do I want to do? I'm the bad paramedic. I want to get mad at her. It's on me. I never told her to. If the tube moves, just let me know, I'll fix it. I never told her that. They don't know that. They don't teach that in EMT class. That's not part of the curriculum. But we're really quick to hand the bag valve mask off to them after we do it. So I'd like to see people practice with Fred the head on a cot. That's what I do. And I make my paramedic students follow the cot around at the college, making sure the tube never moves. Eye gel, same way. Eye gel's the same way. That could move. Yep. If you can't intubate, it's okay. Find another way to ventilate the patient. Oropharyngeal airway and a bag valve mask, an eye gel, a king if that's what you still use. They're all fine. Lung sounds.
There are abnormal breath sounds that you should be familiar with. Snoring, caused by partial obstruction of the upper airway, often caused by the tongue.
Probably during one of my lectures.
High-pitched sound heard on inspiration is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration. Rhonchi is a rattling sound heard in the larger airways caused by excessive mucus.
So we worry about these lung sounds.
Rails.
I don't,
are a
as an
bubbling
EMT
sound
first
heard in the
responder,
smaller airways, typically when they
I really
fill with
don't
fluid,
want you, those
commonly
grapes.
encountered with CHF
I
and
really don't want you to
pulmonary
worry
edema.
about the sounds. I'd rather just have you tell me on the radio, lung sounds sound bad. That's all I need to know. I'll figure it out when I get there. Because everybody's rendition of lung sounds is different. A rhonchi is different than a ralls. A ralls is different than a wheeze. That's why I don't concentrate too much on the sounds. Are they noisy? Yep, I listen, they're noisy. Okay, figure it out when I get there. Not a big deal. The heart. The left ventricle versus the right ventricle is what I want to pay attention to here. And so now, look how thick that is compared to how thick this is. High pressure side is the left side. Low pressure side, the thin wall of the right ventricle, is the low pressure side. Because the right ventricle sends your blood to your lungs, but your left ventricle sends the blood to the whole body. So that's why the left ventricle is thicker, more pulsating, more squeeze. Which brings me to my next 3D model. I'm going to pass these around. We'll start right here. So the bigger heart piece that's coming around is a heart that's had an MI. And you can literally see the dark red tissue on the larger one. That's the dead cells in the heart. The smaller heart there is healthy. And that's what literally goes on. You can see it on a monitor, but you can't literally see the tissue. At least I hope you can't. This is the septum. Look at, this is great. That's the right ventricle. That's the left. You can really see the difference there. These little white things right here, little banjo strings, chordae tendineae. They're not banjo strings. Chordae tendineae. They open and close the valve. And they are attached to papillary muscles. And if you have an MI, such as you can kind of see down there, if you have an MI of the right ventricle and it affects these papillary muscles, that valve will not open correctly. And what happens to your sub pump if it doesn't pump out the water? It backs up. And that's literally how heart failure happens. It's usually from an MI. Here's the heart and the body. I've taken out the lungs here. And that's where the heart. This heart is very enlarged compared to the body of the person. It's an enlarged heart. Why do they tell you to shoot for center mass? If you take a concealed weapon class or self-defense class, shoot for center mass. Yeah, but they never tell you why. Well, I don't have to really tell you why. I mean, you can see it. You can even see more here. Look at the carotid artery. Comes right off the aorta, right up the side of the neck. Not that far off the aorta, that carotid artery. Somebody severs that. We've seen I don't know if you've seen the videos where the goalie gets a skate across the neck. You just see that. That's why. It's just dumping right off the aorta. It's just coming out. This is the pericardial sac right here. What I did is it was wrapped around the heart and I cut it with a pair of scissors and opened it up. Pericardial tamponade is getting blood in that sac and the heart can't beat because of the pressure. The only thing I'm going to say, this is kind of a bad slide. When you're pregnant, your blood volume in the third trimester increases by 1/3. And you get, I'm not going to say the FAT word because that's not the right word to use for pregnant females. You get engorged. The blood's got to go somewhere. So this is a normal female airway looking in the back. That's the third trimester. The airway changes. And I just like to bring that up because it's something you could come across in the field. Overweight people, where's all the pressure from that excessive tissue they've got? You lay them on their back, you could be in trouble. We've actually had to prop people up like at a 30-degree angle to keep the tissue off their airway so they continue to breathe. So we want to make sure we're looking at the whole patient. That's important to me. The spiritual things that we talk about, you got to make sure whatever you're doing with people that they agree to you doing it. And we have a lot of different cultures all over the place. And so you got to make sure you're doing the right things. Body systems. Wanted to talk about these systems quickly. The skeletal system. I wanted to bring it up. I really don't need to. This is awesome. This is all color-coded. I love that. But that skeletal system is a framework. That's anterior view. The muscular system. And you have voluntary muscles and involuntary muscles. The involuntary muscles usually perform organ procedures in your body that you don't have control over. I do a lot of dissections, so I take these pictures, and this is going up the side of the body. There's your deltoid muscle here, external oblique on the side of the rib cage. They really don't, in the field, I will say that muscles really don't mean a lot to us because there isn't anything we can do with them. If we have a muscle injury, a lot of times we treat it like a fracture, and we should. We should, until ruled out otherwise. I just wanted to show you how intense that all these muscles are. I think I've got, so this rectus abdominis muscle here is that center muscle. You know, it's the middle of the six-pack abs that every guy and gal's supposed to have. 2 years ago, I was goaltending in Rochester and went down to make a save, and I did the splits, which I did okay with, but then I extended my body to stop the puck, and I literally ripped this rectus abdominal muscle all the way down to my knees, all the muscles in my legs, my groin, the rectus abdominal muscle, and all these muscles across my abdomen here literally ripped. And when it did, the blood started to seep out, not out of my body, but out to the surface of my skin. And within a half hour, it was all black and blue and swollen, had to go to the ER. I thought I tore an organ inside, and I didn't. It was just from a simple growing tear that went up into the abdomen. It was that. So don't take that stuff lightly. If you get called to a softball injury or something going on, make sure you check them over really good. I drove myself to the ER, but I got chewed out when I got there. So take a look at this. Look at the size of the aorta. If that tears and they're in a car, you'll be running a code. It'll dump out instantly. And same with this. The vena cava, they're both about the same size. If you rip those, good luck. Some surgeons even say if they got ripped on the surgery table, they couldn't even do anything. Integumentary system, that's your skin, regulates temperature, sweating, shivering, changes in diameter of blood vessels in the skin. They constrict, they dilate. The nervous system. We get messages, we process messages, and then they send messages. This is a system, when we put somebody to sleep in the field, our medications, this is the system that our medications affect. When we're good at what they call RSI, rapidly sequence intubation, we put people to sleep, and then we paralyze them, and then we intubate them. And it's all because of this system right here. You've kind of seen some of this already, but this is a mid-sagittal view. Basically, what we did here is cut this body right down. And yes, people, when they donate their body to science, it's in all the paperwork. They know what's, basically going to happen. So a lot of the bodies that we work with have no arms or legs because the ortho department uses them. But we'll use the torso, and sometimes they take the heads off for the neurosurgeons to work on. So I kind of like this. And when I saw this and I came in, if you turn this around, even the colors are almost completely matched because they are yellow. Actually, the spinal cord is. This is very realistic here, I think, compared to an actual spinal cord. Which brings me to my next one. My last two 3D. This one is a .45 caliber gunshot wound to the brain. This is blood. This is an intercerebral bleed. What I did is we took the brain and cut it kind of like a CAT scan machine does, and then we actually 3D printed it. So these are all life size, all the right colors and everything. Look at these blood vessels. And you wonder why you get hit in the head with a baseball and it ruptures. It's pretty easy to do. Endocrine system. You guys deal with this. Diabetics. How many diabetics? That's probably the third or fourth most popular call we run on is diabetics for some odd reason. And to kind of go into that, we'll put dialysis patients. A lot of times dialysis patients are diabetics or diabetics are dialysis patients. So these are all the different, now I couldn't bring in all the different organs of these, but you have these glands throughout your body that help you maintain homeostasis. Constantly working. There's your thyroid gland right here on both sides. There's your larynx. Look at all the blood vessels. Just look at them. Then you wonder why head injuries bleed so bad? That's why. It's just a ton of it. The pineal gland is up here, the hypothalamus. The gland that controls your heat and cold sensory in your body. Kidneys. There's your adrenal gland. Right there. Right on top of the kidney. What comes out of the adrenal gland? Epinephrine and norepi. And your body needs those. Cardiovascular system, probably my favorite system of all. Why do I have this there? This is the only tissue in the body, only one, that has those little tiny discs randomly put through the whole thing, intercalated disc. When you defibrillate somebody with your AED, the electricity goes to the heart muscle, and the electricity will actually follow through all the cardiac muscle to defibrillate it, get rid of the fibrillatory waves because of those. It's the only muscle in the body that has them. It allows electricity to be conducted systematically through the muscle so it all depolarizes at the same time. That's why defibrillation is key to people that go into cardiac arrest in the field, because I think it's like 75% of the time they're in a shockable rhythm. And this is just a cartoon depiction of those intercalated discs. Talked about those already. So this is a heart I opened up. Again, this is the left ventricle. There's those chordae tendineae. That's the valve right there. And they pull it down from the bottom. That's what opens it. So you have tricuspid and bicuspid valves. So tricuspid means you have 3 flaps. Bicuspid means you have 2. And they're placed through the heart. And that's what opens those valves up there. This amount of fat is normal. And I think some of you probably saw there was some fat on those cardiac. That's normal. I've seen ones with fat that thick on them. That's not normal. That's too many French fries and donuts and things like that. There's the chordae tendineae right here. And this is the inside of the heart, the papillary muscles. See, why isn't it nice and smooth? Form to function. If your cardiac muscle and inside of your heart was smooth, you would get blood clots all the time. So whoever made us roughed the inside of the heart up with the papillary muscles so the blood's turbulent, so it never clots. It's amazing. Henceforth, the reason when we go into AFib, the atriums, they're supposed to, go lub dub, but the atriums are quivering. And when they quiver, they don't squeeze enough, so you end up getting blood clots that can form. And that's why people that have AFib are usually on Eliquis or some other type of blood thinner. That's why. This is great. This is one of my most favorite slides too. This is a cross section of a coronary artery. Actually, the left coronary artery. And this was on one end of his heart, and on the other end was this. And that's why he died. He had a widowmaker MI. What happened is this right here was plaque, and the plaque broke open and leaked out a lipid material. It kind of looks like a serum. And the body says, you got a leak. I got to plug it up. So it sends all the red blood cells and platelets to here to plug this up, and it forms a huge blood clot. And that's the only part of his left coronary artery that was open. They couldn't resuscitate him in the field. So on your next chest pain call, or somebody that collapses, think about this. Because to be honest with you, we're going to do our best to resuscitate, but you're not going to be able to fix that in the field. But you don't know that. This is from an autopsy, actually. So, if you would have gotten to him while he was still conscious and still having some blood flow, the nitro would make this dilate a little bit more, but not much more because there isn't much room in there. It can only dilate so far. We got to get him to the cath lab so they can go up his groin, go all the way up and get this clot and pull it out. That's literally what they do in the cath lab. Some patients make it to the hospital, some don't. It's some of the stats I'm seeing now, it's about 50-50. You get a call for chest pain where they're having a heart attack, and you identify it on, you send your 12 lead in or whatever you do. And, yeah, he's having a heart attack. 50% of those patients will not make it to the ER. Respiratory system, we've talked about that a little bit already. Lymphatic system, it just helps protect. It produces white blood cells. That's awesome, we need those. Spleen, what's the spleen do? Anybody remember that one? Produces extra blood cells and stuff. It's like kind of like a small reservoir of extra blood that we have in us. Also filters out some stuff that we don't need. The thoracic duct, that's basically looking down, you're looking at the front. I took off the chest plate in the front. And you can see that the ductwork headed down. That is the aorta, the descending aorta. Look at how, it's probably that big around. And I try to poke holes in it. It's hard to poke a hole in it. I can't imagine if it tears, which is what I've seen in my career. And somebody's just in cardiac arrest immediate. Had a guy fall off a 10-story building and land headfirst in the mud. And when he landed headfirst in the mud, his buddies pulled him out, of course. But his aortic arch, because that's up here, ripped right in two from the force of him hitting the ground. I didn't worry about his neck injury. I was worried about that. Of course, we didn't know that until the autopsy was done. So what happens when you're doing CPR and the aorta's tore? What ends up happening? The blood all just pools in the chest and that's it. GI system, yeah. Get rid of waste, basically. This is just an abdomen picture here of this is a fresh frozen dissection we did. And I just wanted to show you kind of where the organs were. Look how big that liver is. Sits right here. And the spleen, little tiny spleens over here. And we kind of, this is on an embalmed cadaver. It's kind of hard to see, actually. I don't like doing abdominal stuff on embalmed cadavers because everything is shrunk up and closed. It's easier to do on a fresh frozen. Urinary system, I think we all know what that's used for. Look where that bladder sits though. What's right above the bladder? It bifurcates, the aorta does. Ends up going into your femoral arteries. This is a great picture of a kidney. Anybody here had kidney stone? You don't have to tell me. I've had 9. They were made of calcite, which is a mixture of calcium, but iced tea creates the crystals. And that's what was given to me. So I've stopped drinking, and it's hard because I love iced tea. Stopped drinking iced tea completely. And I, not knock on something wood, I have not had one for 5 years. But before that, about 1 or 2 a year. And I had to go to the ER. I don't like that. So, and this is the start of minor, and this is thicker calcium here. This is the start of renal calculi, is what that's showing there. That's what reminded me of it. Male anatomy here. Just keep in mind, hey, I got the female in here somewhere. When females are pregnant, cut them a break. That's the urinary bladder. And you got a baby pushing down on it. And when they say it's time, I need to go to the bath, pull over, do something, let them go. Because I've seen car accidents. This is the symphysis pubis bone here, where a pregnant female was in labor on her way to the hospital, got in a car accident. And when we got there, I could see urine all over the place, but then also she was delivering the baby at the same time. So I have a lot of respect for this anatomy and how it sits in here and that baby coming down on it. I just have a lot of respect for that. But we don't want to judge too quickly, so...
Patient has a fractured fibula. Given him a mild sedative. So he can be able to go in tomorrow.
Daddy's gonna be so excited.
All good.
That killed him.
I love that video. That's so great. So, yeah, I don't want to, you know, as we do things and go into things, I've just got, this is just a quick overview of A&P and what we kind of gone over and stuff. And I'm hoping I tied things in a little bit to maybe make you look at the asthma patient differently, the COPD patient differently, from the inside out. We always see them from the outside. Hopefully we don't see the inside, but we see them from the outside. And we really don't know what that's like. So one of the things I'll do is I'll take a cadaver and I'll wrap their lungs like in a tight band, a latex band, and have people ventilate, and they can't ventilate. That's an asthma patient. Because everything's tightened up, the compliance and the resistance is there. And they'll be like, that's how you, yeah, that's what it feels like to ventilate an asthma patient. So I'm sorry we can't do that here, but I'm hoping that this kind of opened up some different tracks or thought processes to make A&P be more applicable to what you do in the field. That's my point. So now, don't get me wrong. If you come to the cadaver lab, you can be elbow deep in a body if you want. You don't have to. You can stand and watch if you're not really into it. So it isn't that I make you grab hold of the lung. If you want to, you can. If you don't want to, you don't have to. And there's no test either. There's no quizzes or tests. It's all educational. The whole thing is. It's about 3.5 hours, I think, is what we do. So you'll be able to bag valve mask, you'll be able to suction, you'll be able to put oral airways in, nasal airways in, eye gels in, you'll be able to do all that stuff.